it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about hyperparathyroidism. And before we dive into the individual causes of hyperparathyroidism, first let's review our parathyroid hormone pathway. So zooming in over here, you can see that decreased levels of calcium and increased levels of phosphorus are going to trigger our parathyroid glands located on the back of our thyroid to release parathyroid hormone. The main goal of parathyroid hormone is to increase calcium and decrease levels of phosphorus. So basically to trigger changes in these electrolytes that are directly the opposite of the stimuli that we are responding to. And parathyroid hormone is going to increase our levels of calcium and decrease our levels of phosphorus by going to the kidneys and stimulating 1-alpha hydroxylase, that enzyme that is going to convert vitamin D into its active form. Vitamin D in its active form can trigger more calcium and phosphate absorption in the gut. It can also trigger more bone turnover, and this bone turnover is going to release both calcium and phosphorus. The kidney itself, of course, is going to absorb that calcium and excrete that phosphorus, leading to our net increase in calcium and decrease in phosphorus. And if you understand what's happening in that pathway, then you should understand what's going on in primary hyperparathyroidism. Remember, primary conditions are usually going to occur at the gland directly, so our primary hyperparathyroidism occurs at the level of the parathyroid glands themselves, and problems that can occur with these glands that are going to lead to hyperparathyroidism are things like a parathyroid adenoma or just hyperplasia of the parathyroid itself. And this hyperplasia is going to lead to increased release of parathyroid hormone. When we have increased release of parathyroid hormone, this is going to lead to dysregulation of calcium and phosphate, increased calcium and decreased phosphorus. Remember over here, increased calcium and decreased phosphorus was the net effect of this pathway. So when we are making too much parathyroid hormone and we are not listening to the negative feedback, we are making this parathyroid hormone independently of stimulation or feedback that we would have normally. Of course, what we are going to see is an increase in calcium and a decrease in phosphorus, and that's exactly what we see in primary parathyroidism. Our presentation is going to be hypercalcemia. We just talked about this increase in calcium that is going to result when we have too much parathyroid hormone. It's the stones, bones, thrones, and psychiatric overtones. So these symptoms of stones, calcium oxalate kidney stones, thrones, symptoms of constipation or sitting on the toilet and unable to go, bones, bone pain, and psychiatric overtones or psychosis. Additionally, there are a few complications to be aware of with primary hyperparathyroidism. So first, you should be aware of osteitis fibrosis cystica. And osteitis fibrosis cystica is a bone complication that can occur with primary or with secondary hyperparathyroidism. But basically what's happening is, remember when we talked about our parathyroid effects of the bones, what's happening with parathyroid at the bones is first stimulating our osteoblasts, B for blast and B for building bone. Our osteoblasts get stimulated, they are going to release rank ligand. Rank ligand then travels to our osteoclasts, C for crumbling bone and releasing calcium. And our osteoclasts, when stimulated, are going to break down that bone, which releases the calcium and phosphorus into the serum. Okay, great. That's awesome when we are wanting to raise our levels of calcium in the serum with parathyroid hormone. However, when we have dysregulation of parathyroid hormone and this process is discontinuing, then this increased osteoclast activity is going to lead to too much breakdown of our bone, and too much breakdown of our bone is going to lead to these cystic bone spaces with osteoclasts and hemosiderin, and will show up as these brown spots on x-ray. You can kind of see them here, these different brown spots in the bone on x-ray, as well as bone pain. So certainly when you see a patient who has primary hyperparathyroidism, they may also have these symptoms of bone pain or fracture from their osteitis fibrosis cystica, as well as these brown spots in their bones on x-ray. Patients with primary hyperparathyroidism may also present with pseudogout. Remember, pseudogout is calcium pyrophosphate, so if we have increased levels of calcium in the blood, there's some thought that there could be an association there. Additionally, pancreatitis. These are all pretty low yield and pretty rare associations, but I did include them for completeness. And then finally, polyuria. This actually is not that uncommon. Patients with primary hyperparathyroidism can certainly have polyuria, so it's great to think about some of these parts of the presentation as well. Diagnostics for primary hyperparathyroidism should make sense to you if you understand this pathway. First, we have elevated parathyroid hormone. We have increased calcium and decreased phosphorus. And that should make sense to you because parathyroid hormone is doing its normal job at our end organs, even though there's too much of it, and it is increasing levels of calcium and decreasing levels of phosphorus. Our increasing alkaline phosphatase is resulting from that increase in bone turnover, and you may certainly see that on labs as well. And then our management of primary hyperparathyroidism, first we're going to use our calcimimetics like cinacalcet, and our calcimimetics are going to bind at this calcium receptor on your parathyroid gland and turn off the production of parathyroid hormone. And then additionally, we can use our bisphosphonates. Our bisphosphonates are going to act at our hydroxyapatite sites of bone, where they are going to go in, bind to these hydroxyapatite sites, and then shut down the activation of osteoclasts, thus preventing increased bone remodeling and slowing down that process of bone breakdown. And then finally, if all else fails, we can do a parathyroidectomy where we just take out that pesky parathyroid gland, and it will certainly stop making parathyroid hormone once it is out of the body. So that's primary hyperparathyroidism. Secondary hyperparathyroidism is going to be a little bit different in that it isn't acting at the level of the gland. It is a secondary process that is acting at the level of the end organ. And at these end organs, we are going to have something like decreased phosphate excretion or decreased vitamin D that is going to lead to secondary hyperplasia of our gland. So basically, these guys down here are not doing their job, and because they're not doing their job, they're not exerting any negative feedback on our parathyroid gland. So our parathyroid gland keeps making more and more parathyroid hormone, hoping that they'll finally respond, but for whatever reason, they just can't. And one of the reasons they're unable to respond, possibly the most highly tested reason, is in the case of chronic kidney disease. So when we have chronic kidney disease and our kidneys are not functioning normally, that ever important 1-alpha hydroxylase enzyme, the one that makes our active form of vitamin D, is going to have decreased activity because the entire kidney is failing. Thus, we are going to have decreased levels of 125 dihydroxyvitamin D, so lower levels of that active form of vitamin D, which means that the intestines aren't being told to do their job, the bones are receiving less of the signals to do their job, and then additionally, our kidneys, because they're failing, aren't able to excrete the phosphorus as well as they could normally. This means that in addition to having low levels of our active vitamin D, because 1-alpha hydroxylase isn't working, we also have elevated levels of phosphate. And what do elevated levels of phosphate do? You guessed it, they turn on our parathyroid glands. And that is going to lead to this vicious cycle of our kidneys not doing their job, so we have more phosphate because the kidneys aren't filtering it out. That phosphate stimulates more parathyroid hormone to be released. The parathyroid hormone keeps telling the kidneys to do their job, but they can't, so there's no negative feedback, and parathyroid hormone just continues to be made. There's a really nice image over here that I think illustrates this process and the problem that is going on with these kidneys in chronic kidney disease leading to hyperparathyroidism. First, we have that phosphate retention, right, because we're not filtering out all the phosphate like we should be. We also have decreased 125 dihydroxyvitamin D. That means that we have decreased function of our intestines, that we can't absorb as much calcium, so that leads to hypocalcemia. Because we aren't filtering out that phosphate, we also have hyperphosphatemia, and these two things are the two things that are going to turn on our parathyroid glands to secrete more parathyroid hormones. But additionally, there's a couple other problems from this phosphate retention. So because we have all this phosphate floating around, it will actually bind to even more of your calcium, pulling that out of solution, giving you more hypocalcemia here. And then additionally, this calcium phosphate complex can deposit in all these different tissues. So there's a lot of levels to this issue, but the main thing here is that our kidneys are not excreting phosphate or making active vitamin D, and that's going to lead to elevated phosphate, decreased calcium, and increased parathyroid hormone. And as we just saw, because our kidneys are ineffective, parathyroid hormone still isn't able to do its job, and we still have hypocalcemia because there's decreased 1-alpha hydroxylase activity, in addition to the fact that that phosphate is just binding to the calcium and pulling it out of the serum even more. Another possible cause of secondary hyperparathyroidism can actually occur at the gut. So if you have decreased vitamin D absorption from whatever reason, let's say you have IBD or cystic fibrosis or celiac that prevents you from absorbing vitamin D, or you just don't have a lot of sunlight exposure, anything that decreases vitamin D. Vitamin D is actually pretty necessary for the absorption of calcium. So if you don't have enough vitamin D, then you're going to have decreased calcium absorption. You're also going to have decreased 125 dihydroxyvitamin D, this active form of vitamin D, and that is again going to lead to inability of our secondary organs to carry out their end effects here, which means we will not have negative feedback on the system, and our parathyroid gland will just keep making parathyroid hormones. So vitamin D deficiency certainly can cause secondary hyperparathyroidism, although I would say it's a little bit less high yield and a little bit less common to show up on STEP. Our presentation of secondary hyperparathyroidism is actually going to be hypocalcemia. So where we had hypercalcemia up here because parathyroid hormone was just in excess and all of the end organs were still doing their job, here we're going to have a hypocalcemia because our end organs are defective and they are not able to carry out the demands of parathyroid hormone. So this hypocalcemia is going to be an important way that you can distinguish between primary and secondary hyperparathyroidism. All the symptoms of hypocalcemia will also be in this presentation. Things like tetany or rigidity, prolonged QT interval, seizures, Chopstick sign with the tapping of the face, and Trousseau's sign with the blood pressure cuff. Your diagnostics, like we already talked about, increased parathyroid hormone because there's no negative feedback, decreased calcium because we're unable to carry out this pathway successfully, increased alkaline phosphatase, again because we are having increased bone turnover, and increased phosphate, mostly associated with chronic kidney disease. Our management here, in addition to our calcium mimetics, which we already talked about, as well as our bisphosphonates, is also going going to include these phosphate binders like sevelamer, and that should make sense, right? Because one of the main problems here is that our kidney is unable to excrete this phosphate. So if we are able to bind some of that phosphate and decrease the phosphate level in our serum, if we decrease that phosphate level, then we are going to have less stimulation for our parathyroid gland to make more parathyroid hormone, and that's why this is helpful in CKD, although it may not be as helpful in primary hyperparathyroidism where we don't have that phosphate problem. Additionally, we may treat secondary hyperparathyroidism with calcitriol, make sure we're getting enough of that vitamin D that we may not be absorbing if that is the problem. And then finally, we can also do a parathyroidectomy here if this becomes too much of a problem, and taking out that parathyroid will remove that source of parathyroid hormone. Now, the final cause of hyperparathyroidism that I want to talk to you guys about is tertiary hyperparathyroidism. And I like to think of tertiary hyperparathyroidism as kind of a form of primary hyperparathyroidism that results from secondary. That's why we often see it in our post-transplant CKD patients, because your kidneys were letting all this extra phosphate float around, your kidneys were unable to do their job, and you had this elevated level of parathyroid hormone for a really, really long time. And because your parathyroids got so used to overproducing parathyroid hormone just all the time, this led to autonomous hyperparathyroidism. So I'll write tertiary up here with primary, because basically what's happening is, again, this is a syndrome of your parathyroid not listening to negative feedback and just autonomously making parathyroid hormone. So it's very similar to primary in that regard. However, the reason that your parathyroid is not listening to feedback is because it had such a long time with high levels of phosphate while your kidneys had chronic kidney disease, which led to desensitization and autonomous parathyroid activity. So I know it's a little confusing, but whenever you think about tertiary hyperparathyroidism, always see in the question stem if it mentions that this patient had chronic kidney disease but now doesn't. So for example, if they got a transplant or something like that, that will usually be your clue that we're talking about tertiary. Tertiary, just like primary, is going to present with hypercalcemia, because again, maybe your kidneys weren't responding, but now they are. So we are going to have increased levels of parathyroid hormone. We're not listening to our negative feedback, but our end organs are doing their jobs and increasing our calcium levels. We're going to see all those symptoms of hypercalcemia: calcium oxalate kidney stones, constipation, bone pain, psychosis. And the labs are going to be pretty much identical to primary hyperparathyroidism. That's why I say that tertiary is basically primary that came from secondary. So it's increased parathyroid hormone, increased calcium, and decreased phosphorus. And then management, usually you go straight to parathyroidectomy. And then one final complication that I want to make sure you guys are aware of, associated mostly with secondary and tertiary hyperparathyroidism, is that of renal osteodystrophy. So renal osteodystrophy is usually associated with secondary or tertiary hyperparathyroidism from chronic kidney disease. So it's usually only seen if the cause is chronic kidney disease. And this is because we have chronic kidney disease leading to decreased 1-alpha hydroxylase activity, so decreased active form of vitamin D, increased parathyroid hormone, and then that increased bone turnover. And that increased bone turnover is really key here because it'll lead to weak bones and bone pain. This is very similar to what's happening in osteitis fibrosis cystica, but you usually won't see these brown spots in the bone, and the cause may be different as well. Let's quickly recap what we talked about in this video. So primary hyperparathyroidism occurs at the level of the gland. It's characterized by hypercalcemia, so increased calcium, and low phosphate. It is also associated with osteitis fibrosis cystica. Our secondary hyperparathyroidism occurs at the level of our end organs. It's usually caused by CKD or vitamin D deficiency. It is going to be associated with decreased calcium and increased phosphate. Our tertiary hyperparathyroidism really only occurs after the correction of chronic kidney disease with a transplant. It is also going to occur at the level of the gland that is not listening to feedback and is acting autonomously, and it will also present with increased calcium and decreased phosphate. And then how would they ask you about this on a board style question? Well, something they might ask is, a 65-year-old woman presents after a ground level fall. Medical history is remarkable for chronic kidney disease, for which the patient receives dialysis Monday, Wednesday, and Friday. X-ray reveals L4 and L5 fractures. In addition to treatment of her fracture, the physician recommends initiation of a medication which will directly inhibit continued bone breakdown. What is the mechanism of action of this medication? So our patient has chronic kidney disease, and then she had this ground level fall resulting in a spinal fracture. That leads me to believe that she has some kind of bone weakness. And bone weakness associated with chronic kidney disease could definitely be renal osteodystrophy. So I'm thinking about some sort of renal osteodystrophy, hyperparathyroidism from chronic kidney disease picture. Definitely sounding like secondary hyperparathyroidism. The patient is started on a medication that will directly inhibit bone breakdown. That sounds like bisphosphonates. Those are pretty much the only medication that are acting directly at our bone here. Our phosphate binders aren't acting directly on the bone. Our calcium mimetics are acting more at the parathyroid gland level. So bisphosphonates definitely seem like the medication they're talking about. And they ask me what the mechanism of action is of this medication. Like we talked about in this video, the mechanism of action for bisphosphonates are binding to these hydroxyapatite sites on bone and stopping the activation of osteoclasts. So I would look for something like that in my answer choices. Now that's all I have for you on hyperparathyroidism. I hope this video was helpful, and I'll see you next time.